welcome for the introduce. Actually, I'm not the neurologist, and I'm not a radiologist also. I'm a sonologist, the man who do ultrasound whole body. Yep. And someday when I do the ultrasound whole body, I found that I can see the nerve. And when I try to do it day by day, year by year, and I can see the nerve inside the muscle belly, and it's so advantage with me. And give me thank you to Professor Kong, who give me a lot of case to make this presentation. I start my presentation. For ultrasound examination for normal morphology and disorder of brachial plexus. For introduction, the brachial plexus is the most complex structure of the peripheral neural network and can be affected by trauma, irradiation, cancer, infection, and autoimmune inflammatory disease. MRI is preferred in imaging brachial plexus. However, high-resolution ultrasound nowadays can be seen the most powerful tool for assessing peripheral nerve disorder. Although ultrasound examination of brachial plexus lack of visibility of the origin where the nerves come from the spinal cord, but for another, we ultrasound have many advantages for the mobility, cost effectiveness, real-time imaging, and easy access to the guide invention. Understanding brachial plexus pathology and ultrasound examination can very helpful in the diagnosis and intervention of this plexus. Now we come to the ultrasound examine the brachial plexus anatomy. Most of us will useful, very difficult to understand, remember on the plexus. Now we can just remember only the C7, why it's in middle, and upper you have a C5 and C6 to become the superior chin, and you lower like C8 and C1 in the lower chin. As well, you just remember the C7, and on three chin divide into division, anterior and posterior. The three posterior division mesh to form the posterior cord on we know, right? And we have three anterior cords. The anterior cord division from the upper and the middle will form the lateral cord, and while the anterior division of the inferior chin from the medial cord. So easy. And the posterior, lateral, and medial cords are named by the position with respect to the axillary artery. So if we scanning in the artery, the axillary artery, we can see, we can name it easy on ultrasound image. The posterior cord separate into radial and axillary nerve. Why I can remember? Because the position of the radial and axillary in the back of the arms, right? So we can easily remember posterior cord will divide to axillary and radial. And the lateral cord separate into the musculoskeletal nerve, and the medial cord separate into the ulnar nerve. How we can remember? The ulnar you see is in the medial side of the hand and elbow, so we can remember it's in the medial side, right? Easy. And the medial nerve consists of broad bundle of the lateral cord and the medial cord. So we can, if we see back from the picture here, we easy to remember. You just see the middle, and you see the C7, and upper is superior, and inferior the lower. You see, and you just remember here the posterior is three posterior, and lateral and medial cords. And we can see the medial side of the arm. We can see have a ulnar nerve, and the lateral we have the musculoskeletal nerve. The musculoskeletal nerve have one lateral side, one branch from the lateral, so we can remember it's come from the lateral cord, and axillary nerve, radial nerve, it come from the back, right? And related anatomical structure, we have to know the related, because the scanning of the ultrasound is so small. It's just small like this. So we cannot scan on in one time. So we have the landmass, the mark to discover on. So you have to first rib, you have to identify the first rib and the first costal chamfer zone. So after that, we can have some information like the C7 chamfer process had no vertebral hole, while the C6 chamber process have the hole, the first hole where the vertebral artery go through, and we have the nerve roots located behind and after laterally the vertebral artery. The roots locate between the anterior and posterior tubercle of the vertebral chamber process, like C1, C5, and C6. You see have two process, and in the scalene space between the anterior and middle scalene muscle, where we see the trisum and some roots. We also know about the subscleral artery. The clavicle and the first rib create the gap between and the plexus will go back through this. So we can see here in the image, we can see the first rib, right? The first rib, and this is the tip of the lung, and this is the first rib. And when we identify the first rib, we identify the T1 process, chamber process of T1. After we calculate up, and we assign C7, C6, C5. And we also based on the first chamber process, which have a vertebral artery hole, is usually C6. We can see here, this is the vertebral artery, and this is the vertebral artery, and you see the nerve here. It's passed through the first, it's usually the C6 chamber C6, but sometimes it can be C5 or C4. And after that, we redress the inferior edge of the probe outward, and as angle of 45, we can see the nerve like this in the longitudinal scanning. And when we cast in the axial plane, we can see this is the anterior and the posterior process of the chamber process of C5. So this is the C5 root. And we also have some scan like MRI for sagittal or coronal to have some image like this. You can see C5, C6, C7 in one plane in longitudinal. And we can see this is the T1. We can see in the C5, C6, C7, C8, and we see the T1 very near the inner border of the first rib. And on the inner scalene muscle space, we can see the brachial flexus here. We just use the normal probe. We can see it very easy. Like this, we can see inter space. C1, C6, C7, C8. In many cases, we also very easy to see. And when we move down the probe, we can see it's divided into the upper, middle, and lower chunk in the interscalene muscle space. Yeah, I have in my here. I have a clip here. You can see we move down, and we see it's a connect. This is C5 and C6 to become the upper chunk. In the suprascapular fossa, the brachial flexus is from the line, a graph Y bunch. We move the probe in axial section from the trisum to the suprascapular fossa. We can observe the separate into anterior and posterior chunk. You can see like this. It's become the like a graph bundle. And when we and beneath the clavis, the plexus that surround the subclavian artery, naming the nerve fiber is difficulty. It's so difficult, and but we have to possible to identify by we scanning from down to up. When we scanning from the arm and go up to the armpit, we can see we can name in this bundle, this fiber, like this. And usually in this time we use the hand like this. We put the hand like this and we scan in up from down to up to the arm to the armpit. We can see it divide into many causes. And when we familiar with on the landmass, we can easy to identify the on the structure very easy like this. You can see I do like this, scanning in the axial plane, and I move down, and you see C7, C6, C5, C7, and we see C8, and we have a three chunk, and we have a two division. chin. Now I come to the brachial pressure trauma. Because I have short time, so it's fast. And for tie up the pressure trauma, we have a normal like this, and avulsion is near the spinal cord, and a rupture is after the ganglion, and neoplasia is thinner and neuroma. Brachial pressure avulsion. This is a case, a 20 years old male with the clavicle fracture injury. You can see here, after it's healing here, it has scar in the bone. And the C1, C5, C6 on the nerve roots, we cannot see easy like the normal. But when we scan in, we can see in near the C7 and T1 vertebral bone, we can see like a cyst here. It's called the pseudo-meningocele in C7 and T1 bone. And we cannot see the roots, but when we scan in, we see it's combined like a mass here, very hypoechoic mass. And with this, we can see it's a brachial pressure avulsion. It's easy when you see the pseudo-meningocele here near the border, near the in the right edge of the bone, cervical bone. And you see here, this is cyst. It's not continuity. It's cut here. This is another case. The 38 years old male with right clavicle fracture injury has combined bone. When scanning, we see the absent C5 to T1 nerve roots from the head of the vertebral to starting from the spine, and it's forming pseudo-meningocele across the right band of the C7 and T1. You can see it in the MRI image here. This is the pseudo-meningocele here in the border of the C8, C7 and T1. And you can see the same image in ultrasound. You can see here in the clip. When it's scanning, you can calculate. I can calculate the C5 to C8 root, and it's the same. If it's the same, it may compared to the MRI. You see, you see the coronal plane, and this is the sagittal plane. And brachial pressure rupture after the ganglion, we call it rupture. And we can see here when scanning from C4, it's continually. C5 the same, C6 the same, but C7 and C8 you see it's cutting here. It's not continually. Yes, and the further you can see it's not continually here. The C7, yes, and it also mark a mass in the clavicle fossa. Upper clavicle fossa here, compared to another side, it's normal, like the graph right bunch. Circular of a post-patient brachial pressure injury. 129 years old female came to our hospital because her right hand were weaker than her left hand, and her shoulder wide is shorter than the left. You can see the picture here. You can see the right shoulder is shorter than the left side. And she wants answer. She wants to ask why I have this. And when I scan in on the arm, the shoulder, you can see here the muscle in the right side is thinner than the left side, the normal side. Here, you can see here. The supraspinatus and infraspinatus compared to the right side is smaller. And but the brachial pressure is bigger. You can see the upper, middle, and superior is bigger than the left side. The chin is bigger. So I asked about history. She said that when she was born, a few months after born, she cannot move his hand. She cannot move this hand. and after a few months, it's recovery. And I think that maybe she have a post-brachial brachial injury when she was delivery. Inflammation of the brachial plexus. 46 years old male with right hand muscle after herpes zoster infection. Electromyography lesion damage of the superior and middle chin and serious damage to the upper chin. Ultrasound then saw an increase in the size of the roots that form the upper chin, the middle chin, and the two divisions separate from the superior chin. And also the axillary have the same feature. And we can see the edema of the tissue around the nerve. You can see I compare the C5 and C6, C7 in both sides. It's on more black and bigger. And when we do the MRI, you see the same. It's bigger and more hyper intense. And this is one case of the post-herpetic brachial brachiopathy. In another plane, you can see, compare another plane, you see here. We compare to the two divisions of the upper chin. And also the axillary nerve in the right side bigger. Personal tunnel syndrome. 37 years old female with weakness in the left hand muscle for 1 year. Had surgery on the cervical spine, but now improve the symptom. You can see here is he have a surgery because he have a stone, the connective fusion of the bone here. And for the muscle, you can see the deltoid muscle, supraabdominal muscle, and bicep muscle on in the left side is more wide, right? Hyperacuous, and it's smaller than the opposite side. And when scanning for the brachial plexus, you can see it's more black and bigger in the chin bigger. And also we can see the anterior division more bigger of the upper chin in the left side bigger than the right side. Which combined to the Dr. Kong, we see that this is a personal tunnel syndrome. The brachial damage after radiation therapy. This is the case. 64 years old female. She feel numb in the 4 and 5 finger on her right hand, and she have another decompression surgery on her wrist, but she have no improved symptom. She had radiation therapy for her neck for 20 years ago when she was treated for nasopharyngeal cancer. Ultrasound so fibrosis of tissue around the brachial plexus. You can see here, this is the CA. You can see here the CA. Like Dr. Simmons say, when it fibrosis, it's more wide, right? It's bigger and it's more wide. And it's not, it's a heterogeneous and hypocrite a little bit. And it's irregular outer border. And this is for the MRI. After that, we send her to do MRI. We can see the same at the CA is the have a bigger and also in the C6 have the same image. So this is one case of for because he have the for radiation and it affects for many years after radiation exposure. Yes, we can see here we use the Doppler. I use the Doppler, and I can see this is the artery with the signal Doppler inside, and this is the nerve roots, the CA. So my presentation is stopped here. Thank you for your listening.